Okay. Good afternoon, everybody, and welcome. I'm really excited to welcome you all to this complimentary webinar on the upcoming changes to the E&M guidelines for nursing homes and home or residence service providers. My name is Rob Del Giorno, and I'm the chair of the Investigations, Audit, and Compliance Group here at Garfunkel Wild. I'm joined today by the president of Garfunkel Health Advisors, Alicia Shickle, and her associate, Simon Chaykler. Back in 2020, we were here getting you ready for the 2021 E&M changes, and we're back at it again, helping everyone get up to speed on the 2023 changes. For those of you who were familiar with the 2021 changes, you will see a natural progression here and a continuing focus on coding levels being driven by medical decision-making and an effort to ease documentation burdens, but we'll see if that's really accomplished. Garfunkel and GHA are always ahead of the curve on changes in the healthcare industry. And in this case, so much so that after we booked this date for the presentation, CMS ended up issuing its own E&M guidance. And we built that here into the slides, and they seemed to piggyback us yesterday by hosting their own presentation shortly after ours. Before I turn this over, I want to let you know that there's going to be more to come here on the compliance front. Okay, we're launching a great compliance lunch and learn series, bringing in all types of healthcare folks, but with a focus on compliance and compliance officers. It'll kick off in December. We'll be covering the compliance program changes in New York that have been proposed and commented on. We'll be expecting those to come out in early 2023. And we'll follow it up with another program for a discussion on what your compliance program requirements are and offshore data requirements for those of you contracted under managed care agreements. So let me turn this over to Alicia Shickle. I could go on and on about her. And if for those of you, and I know I've seen the list, I know many of you have worked with her, you know exactly why. She is excellent at what she does. She's well respected in the industry. She's been a fantastic partner for us. And she has put together, along with Simon, a great presentation for you. The slides and recording will be sent for you and also posted on our sites. Also, we're happy to have you be interactive and post your questions, put them in the Q&A box. Let me turn this over to Alicia and Simon. They can tell you more about themselves, GHA, and kick this off. Let's go, Alicia.
Awesome. Thank you so much. Hey, we are so grateful that you are tuning in to spend your lunch hour with us today. We have an action-packed hour. So, today is going to be a high-level overview. We are going to dive a little bit into the weeds. So I'm Alicia Shickle. I've been in healthcare about 36 years. I have a lot of experience with revenue cycle and compliance and documentation and coding. Simon is an amazing addition to our team in the past year. He also has extensive experience in revenue cycle integrity, documentation coding, billing processes. He is certified, and he is an amazing addition to our team. A little bit about Garfunkel Health Advisors. GHA is turning 2. Amazing. It's been a really great and busy time for us. We are a full service advisory team of experts in the industry. We have decades of experience. We have a lot of experience. We do a lot of work with our clients on all aspects of the revenue cycle, but we really have a niche area of focus in documentation and coding. We have a full suite of audit services, both for compliance purposes and when providers are in need of retrospective or overpayment recovery support. And we also offer a full suite of credentialing services. So feel free to tap into our website, call us. We're happy to give you more information on that. A little disclaimer, we all know the only constant in healthcare is change. So all of our content is appropriate and up to date for today's presentation. Just please be mindful that things change very frequently, as you know, and some of this content may change after today's presentation. All right, so our goals today, we want to talk about the progression from the old guidelines, 95 and 97, to the 2021 guidelines. And then that model has now been being adopted in 2023 for all other E&M services. So great that we're coming together today to talk about this. We're going to go over the guidelines and overview. We're going to take you into the weeds on the medical decision-making and the time-based requirements. And then Simon has done a great job putting together all of the technical changes that you need to know that impact the specific codes that you use. So we'll get to that at the end of the presentation. And then definitely want to have time for Q&A. As Rob mentioned, hey, just plug your questions into the Q&A section. And if we can't get to them during today's presentation, we will absolutely follow up with you. Just one other thing, we have had some questions about CLE or CME. Today's webinar does not, we're not offering any CLE or CME, but I'm sure we are looking into that for future presentations. So, okay, Rob.
Let's have a little, interaction here. I'm going to post a poll as my mouse just froze. Let's give that a second to come on back. But we really want to get a sense to see where people are in terms of their, knowledge and preparation for these changes. So we popped the poll up here for you. The answers are flying in already. We'll let that run for a second and see where people fall. Is great. The level of participation is great. Keep going. Give you another few seconds here to get your answers in. They keep going. They keep going. I'll give you another.
Awesome.
Any more? Going once. Okay. We're pretty good here. We've got over 80% participation, and we're going to end the poll and share the results. Not really that surprising, given such a change. So it looks like we have 20% didn't know these were happening. The majority of you fell in the middle. I'll tell you, yesterday, large audience with us, and these are really pretty consistent all around. A small percentage of people already prepared. Most have done a little bit or knew about it. So you seem to be consistent with what we've been seeing. So the obvious point, this is going to be helpful to everybody. So I'll let you back at it. Go ahead.
Yeah, terrific. Well, great. So that is so helpful to kind of get a gauge on where everyone is. I really do want to say, it is November. These changes take effect January 1st. So you do have some time to get ready, and we really recommend that. I mean, we'll talk a little bit about at the end some lessons learned from the inception of the 2021 guidelines. So it's really to your benefit, both from a risk perspective, but also to make sure you're capturing all of the revenue for the services that you're rendering. So we'll dive into that a little later in the presentation. We want to take you through the evolution of E&M services here. I think many of you who are probably going to fit into these categories of E&M services, nursing facility, home or residence services, are probably already, utilizing the 2021 E&M guidelines. But for those of you who are not, and you're still leveling under the old guidelines, those guidelines have the 3 key components: the history, the exam, and the medical decision-making, which we're going to talk about that in depth today. But we really haven't seen an update in these guidelines for over 25 years, back when the 2021 E&M guidelines rolled out the updates. So as we predicted in the industry, after 2021, office and outpatient setting visits, we predicted this was going to happen, and we were hopeful because it's such an amazing change for providers, doing away with the old nuances of the key components, moving into the natural progression of how you see patients, what's clinically appropriate, getting rid of all the massive garbage in, garbage out, 10-page note for, one visit, all ridiculous. So these changes that are going into effect in January, they impact hospital inpatient observation care services, consultation codes, that's applicable for you. Simon's going to go over those, emergency department services, nursing facility, both skilled and regular nursing facility services for providers who render care to patients in their home or their place of residence. And then we'll take a look at the prolonged service codes at the end. All right, Simon. Okay. The one big thing here that has not changed is medical necessity, right? Payers don't pay for services that aren't medically necessary. How do you back up and support your medical necessity? Through your documentation, you communicate the medical necessity for the services and procedures that you're providing to the health plans through your diagnosis codes, right? So really important. We're not going to talk a lot about diagnosis coding today. Be aware those changes come out in October. There were a ton of new changes to the ICD-10 codes this year, over 400. Really important, make sure you're coding to the highest level of specificity. Make sure that your documentation, it's not about quantity, it's about quality, is there to support the medical necessity for the services that you're rendering. Okay. Clinical documentation. All of you who know me, and all of you who hopefully will get to know us, know that when we get to this part about documentation, I always get up on my soapbox because over 36 years of working in this industry, I can't tell you how much provider defense, how do you, support the services you're billing for if you become under audit by a health plan. It's in the documentation. The key to all of this is in your documentation. So it's so critical to make sure that you, as the providers, understand what's required for the services that you're rendering to get into the documentation. And not only does that help you, of course, the first course and reason for documentation is patient care, right? But then you've also got to be able to back up the services that you're rendering here. So here's some of the things. We put together a little checklist. We're not going to go through in detail, but you should be documenting things like newer established patient. Why? That helps your coders and your billers to have adequate information to be selecting the proper and correct codes for billing purposes. Maybe you select the codes, maybe someone else is going to select the codes, but the documentation is critical. You've got to have a chief complaint. Why are you seeing that patient today? All your relevant medical history, exam. Simon's going to talk to you in detail about that. Yeah, those components aren't going to be counted under the new guidelines, but you still have to have them in the documentation. Orders, plans of care, change of status, document timely, right? All of that's going to back up your medical necessity. And if you're not sure, go back to your old SOAP note format, right? Sometimes going back to basics is absolute best. All right, Simon. Okay, so we know that the changes came out initially by AMA. They published the CPT book and all the guidelines. CMS, while they have agreed to adopt the lion's share of these changes, there are still areas, just like under the 2021 E&M updates, that they are not adopting, or they have a slight change in their definition or their description. Prolonged services were not adopted. They have their own codes. They have their own rules behind that. So we'll look at some of that. So just be mindful. Simon is going to throw out a little caution like, hey, these are the AMA guidelines, and this is an area where you really want to update and make sure you're following, that there's some differences in the CMS guidelines.
Okay, so that was
Oh, sorry. Thanks, Simon. I'm sorry. I wanted to say this is a great segue for Simon to kick us off to take us through some of the actual changes. So go ahead. I'm sorry.
Yeah, so that was an excellent introduction on how we got to where we are today. So new versus established patients, pretty much we don't see any changes to the definition of new and established patients from the old guidelines that everyone is used to. So just a quick recap on the CPT definitions. A new patient is one that has not received any services within the last 3 years. from the same exact specialty or subspecialty, whereas a subsequent visit or patient was seen within the last 3 years by a provider in the same exact specialty and subspecialty and belonged to the same group practice. Initial versus subsequent visits. So this is a new section that was added by AMA for face-to-face services that are rendered in the nursing facility setting. So note that the definitions are related to AMA's CPT guidelines, and CMS will have slightly modified definitions and guidelines due to not recognizing subspecialties as one of their components. So initial service is when a patient has not received any services from the provider of the same exact specialty or subspecialty during their nursing facility stay. Whereas a subsequent visit, the patient has received some type of service already from the provider of the same exact specialty and subspecialty during their admission to the nursing facility. So a good way to remember this is that did any of the providers in the same group practice and in the same exact specialty and subspecialty see the patient during their nursing facility stay? It's one thing to note that any PAs or NPs that work alongside the doctors will be considered as if they are working in the same exact specialty and subspecialty as the physician. So another thing, the code selection categories will now depend on whether the provider of the same exact specialty or subspecialty has seen the provider during the admission stay. So these codes and guidelines are based on the admission stay. So during a nursing facility stay, the provider will only be allowed one initial service, and then any follow-up services with the patient will be considered as subsequent encounters or visits. If the patient is discharged and then admitted to the nursing facility in a month, let's say, then the provider can report the initial service again for the new patient admission. AMA has also provided clarification in the guidelines for data to be reviewed and or analyzed and reported it separately. So this area is where we see a lot of providers struggling to decide whether or not to count data to be reviewed or analyzed when ordering and reviewing tests. So AMA has stated that if a provider performs any type of professional interpretation of a test, let's say ECG, and is billing for the service separately, then they would not be able to count it towards the medical decision-making level. Meaning that when a provider is billing separately and there's a separate CPT code, it will already encompass the ordering and interpretation of that code. So it will be considered as double dipping, and Alicia will walk us through that when we get to the audit tool. On the other hand, any tests that do not require separate interpretation or a professional component, such as, let's say, urine analysis or point of care glucose or strep tests, those may be counted as either ordered or reviewed for the medical decision making. And the reason being for that is that there is no professional component to these lab tests. They're kind of more of a technical component where you just are reading the results off the machine. Again, the intent here is to prevent providers from gaining in the E&M level if they're already billing separately for the procedure performed. History and physical exam in 2023. So we're going to see a major change in the AMA guidelines for history and physical examination. So under the new guidelines, a medically appropriate history and physical exam will be required, and it will no longer be used in the determination of the level of the encounter. So although history and physical is not going to be used in the leveling of E&M services like everyone is used to in the past, it is still an important factor in the determination of medical necessity for all encounters. So it will now be the provider's responsibility to perform what they feel is necessary and appropriate in the history and physical examination at the time of the encounter. And the medical record should include the pertinent history and physical examination components for continuity of care. The extent of those documentation will now be up to the provider for documentation purposes and not for the leveling of service. So you won't need to count how much physical exam components, did you review the skin, did you review cardiology, and so on. So during the nursing facility stay, the provider should capture any patient's pertinent history and perform a relevant physical exam, as it will change from day to day. So for example, if the patient was admitted to the nursing facility due to, let's say, altered mental status, then the physical exam should reflect the patient's mental status from day to day. Did the mental status of the patient improve? Did it worsen? Is it stable? What is it on the day of your encounter? Again, documentation will be your only line of defense and must be relevant to the date of the encounter. On the other hand, if a provider presented to the patient's home for abdominal pain, then the physical exam should reflect the examination of the patient's abdomen. Is it soft? Is it tender? Is it non-tender? What is your evaluation of the patient? So how will 2023 E&M guidelines affect your documentation and correct code selection moving forward? So similar to the 2021 E&M overhaul for office and other outpatient settings, starting January 1st, 2023, providers will now be able to select their level of service either based on medical decision-making or the total time spent on the day of the encounter for nursing facility and home-based encounters. The goal of these new guidelines is to reduce administrative burden on documentation while allowing providers to document what is relevant and important to that date of the encounter, as it will most likely change in a nursing home facility from day to day. So as an example, if you're a cardiologist in a nursing facility, it may not be necessary for you to review the patient's skin, to do a musculoskeletal system evaluation if you're controlling them for uncontrolled blood pressure, right? So as a result, documenting an appropriate history and physical for your specialty will ensure that you are meeting the medical necessity and that the coders, auditors, insurance carriers, and so on will understand the complexity of problems that you are addressing during the encounter, as it is part of the medical decision-making process. So within each code categories, we're going to see a different amounts of E&M levels for reporting purposes. And later on in the presentation, we will go over the consultation, nursing facility, and home-based encounters, how to select the proper codes. And I will now turn it back to Alicia to walk us through the medical decision-making and time-based coding.
Hey, thanks, Simon. So we have a question, which I want to take a second just to answer, because we had the same question yesterday, which we were preparing those to get out to everyone, but I think it's important. The question is, if a doctor starts working in a new practice and he's seeing a patient from his old practice and it's within the 3-year time period, is the patient considered new or established to the practice? And they put in, quote, in parentheses here, it's a different tax ID number and a new group NPI number. And Simon and I had a discussion about this before the presentation.
Yeah.
The answer is that the patient is established. The tax ID number doesn't matter. The group number doesn't matter. It's going to go by the physician's NPI, the rendering provider's NPI number. So if a provider works in a group and he brings all of his patients over to a new group, he's seeing those patients within 3 years, and that patient would be considered established. So
yeah, and
that's helpful.
Yeah, and the best way to remember it is that it is considered based on professional services, not on group tax ID. So if
Right.
the patient has received any type of professional service from the provider anywhere, they will be considered as established.
Right, perfect. Okay, so we're
Okay.
gonna jump into medical decision-making. I know a lot of you might find this daunting, but we love it, so we hope we keep it entertaining for you. The great news is, like, listen, when we were training and providing education on the old guidelines, we had those three key components. One of those components was always the medical decision-making. And we always focused on, hey, even if you have to meet two of the three key components under the old guidelines, you still had to meet the criteria, at least in the medical decision-making, right? So the good news is that a lot of this is going to be very familiar to you. The components of medical decision-making have not changed, the elements, right? The components with inside them have changed slightly, and we'll take you through what those look like. But as Simon mentioned, the whole purpose behind this is to simplify how do you pick your level of service. So, all right, medical decision-making, what is it? It's the process for the provider to establish their diagnosis, go through assess status of conditions, and the process of selecting a management option, right? So the three elements of medical decision-making are the number and complexity of problems that you're addressing during the encounter. We want to highlight that word. Simon mentions it a few times. We're going to tell you why that's important. The amount and or complexity of data to be reviewed and analyzed, and then the risk of complications, of morbidity or mortality, of management decisions made at that encounter. The four types of medical decision-making have not changed. They're still straightforward, low, moderate, and high, right? So this kind of makes it easy for us. To qualify for a particular evaluation and management level of medical decision-making, you have to meet or exceed the criteria in two of these three elements, right? So either the number and complexity of problems and the risk, or the data and the risk. However that comes together for you in your day-to-day workflow and how you're seeing your patients, it doesn't matter. Two of the three have to be met or exceeded. And we'll take a look at what that means from a practical perspective. All right, this is really important. When AMA came out with the 2021 E&M guidelines, they did a great job of giving us clear definition behind some of the common terms that we deal with of when we're picking our levels or we're going through the information on in the E&M guidelines. Two things I want to focus on. Again, you know, we're limited on time today, but these are really critical, right? So a problem, what is a problem? It's a disease, condition, illness, injury. It's a symptom, a sign, or any other thing or matter that you're addressing during that encounter. You're not always going to be able to make a diagnosis. So it's okay to code for signs and symptoms. Patients may have many problems, but the key here in picking your level and your documentation is going to be how you are dealing with problems that you are addressing during the encounter, right? So a problem addressed or managed is when it's evaluated or treated at that encounter by the provider. What does that mean? We like to give you the term MEAT, M-E-A-T, which if you're familiar with any risk adjustment coding or risk-based models, MEAT stands for monitored, evaluated, assessed, or treated. So if you're not sure that you can count a problem as a problem addressed, just remember that acronym. Am I monitoring it, evaluating, assessing it, or treating it in this encounter? Okay. Really important to remember that you're going to level your service based on the patient's status in today's encounter, right? And we say here, this is applicable both for inpatient or observation and in the nursing facility. Maybe their diagnosis on admission is going to be much more severe than 3 or 4 or 5 days into their stay. But your level, the problem addressed is going to be the status of that problem at today's encounter. Okay, Simon. we put together, we're not going to go through these in detail, but this is a really important component of understanding the complexity of problems that you are dealing with and how those problems and issues that you're addressing are going to fit into this first component of medical decision making. So right now we're talking about the number and complexity of problems that you're addressing at the encounter. Here are the definition of some common types of issues that you're going to deal with. And these are the terms that where they plug into the audit tool, which we're going to look at. So acute uncomplicated illness or injury, basically the AMA gave that a definition. What does that mean? It's a recent or short-term problem, low risk of morbidity or mortality for which treatment is considered. And basically you're expecting the patient to have a full recovery without any functional impairment. They actually added this a new category under the 2023 guidelines to include requiring hospital inpatient or observation level care. Okay, Simon, you can see as we progress through these, the more complex the problem, the higher level medical decision making this is going to fit into, and we'll hopefully it'll come together for you when we get to the audit tool. Stable chronic illnesses, I think it's important to just quickly say, hey, chronic was defined, stable was defined. Chronic is a problem that's expected to last a duration of at least 1 year or until the death of a patient. Stable means that that patient has actually met their specific treatment goals. Anyone who has not met their treatment goals for a specific condition is considered not to be stable. So if you're deciding, hey, should I pick a stable chronic illness? Should I, where does this really fit in? The AMA gave great definition of where patients fall in these categories. Okay, Simon. Again, chronic illness with exacerbation, progression. I think in the nursing facility, you're probably going to start seeing a lot of these more moderate to high level problems. Again, multiple problems. Just because patient has multiple problems is not as much applicable as all of those problems that you're dealing with, right? So if you're dealing with that problem during today's encounter, you're addressing it, monitoring, evaluating, assessing it, or treating it, you can count it towards the level of service for today's encounter. Go ahead, Simon. And like Rob said, we're going to get you the presentation. You can always go back through these. These are built right into the AMA guidelines. And then this one, just to mention quickly, acute or chronic illness or injury poses a threat to life or bodily function. This is your high level. This and acute exacerbation are the two conditions that fall into high level medical decision making. So this in conjunction with meeting the criterion data and or risk will allow you to select those higher level services, and Simon will actually bring this together for us at the end when he shows us the actual codes. Okay. All right, the data section. Now moving into the second element, data. So this is one area. We always had a data component under the old guidelines as well. This is where we're going to see some pretty significant changes. It looks a little complex, but really when you look at it from a practical perspective, it's all things you're doing. This has really been simplified. So the data section has been broken out into 3 categories. The first category deals with any tests that you're ordering, any documents that you're reviewing, if you have to get the history from someone other than the patient, an independent historian, and the higher level service, the more data elements are going to be required, right? This is the first section here is where Simon mentioned like, hey, when can you and when can't you count certain tests? So the AMA came out with clarity on this. At first, when the regulation came out in 2021, they said, hey, if you're billing separately for a test and you're submitting that CPT code and getting reimbursement, you cannot count it towards the level of service. And I'm mentioning this because I had a question about this yesterday. AMA then came out with a technical update that said, okay, if it's a test that you are analyzing, and they define analyzed as, hey, you're not actually doing the analysis, but we considered analyzed, like you are taking that result and you are considering that in your medical decision-making of how you're going to treat that patient today. So as Simon mentioned, like lab work, glucose, urine, they don't require an independent interpretation, or they don't have a professional component, but they come back with a result and you say, hey, yeah, that urine is not good. I'm going to consider that in my medical decision-making, how I'm going to treat the patient today. Even if you're billing for it separately, you can count that as a one unique test towards your medical decision-making level under the first category here. Okay, so that being said, if you're going to order a chem panel that has 12 tests in it, it's one CPT code. It's considered one unique test. So for purposes, just to simplify this, if I need to count 3 unique tests and I order a CBC, a chem, and a urine, right there, I've met my criteria that I've ordered 3 unique tests. Okay. The second category under the data section is independent interpretation of a test that's been performed by another physician or healthcare professional that's not separately reported. What does that look like? Hey, you have an EKG, someone else did it, you have an interpretation on that, but you want to read that EKG yourself, right? You're going to document in your medical record. You don't have to do a formal big, hey, here's my independent interpretation. You do have to document in the medical record that you reviewed that test. Here was your findings, your interpretation, and then, hey, this is how that's impacting my medical decision-making today for today's level of service, okay? And then the third category is discussion of management or test interpretation with an external physician or other qualified health professional, right? Maybe an NP or a PA, or appropriate source. And I just want to clarify, what does that mean? Other appropriate source may be another professional who's not a healthcare professional, but they're involved in the care of the patient. So it could be their attorney, it could be, a caseworker, case management worker, teacher, I don't know, in the setting of a nursing home or facility, probably, I don't know how often you'll see this, but it does not have to be a professional, just someone else who is a healthcare professional, someone else who's involved in the patient's care. Discussion requires interactive exchange between providers or the other appropriate source. You can't just send documentation back and forth, notes, that doesn't qualify. It doesn't have to happen on the same day. Maybe I reach out, hey, Dr. Rob, I have some questions on this patient. Dr. Rob doesn't get back to me until tomorrow. I count that encounter when I am using it in my analysis for medical decision-making for the patient. So it may not happen today. One thing I just want to back up and talk about is Simon mentioned, ordered, reviewed. When you order a test, there is an expectation that that test is going to be reviewed. So you take credit for it when you order it. If you have to order a test outside of an encounter, maybe in the middle of the night, you haven't seen the patient, the nurse calls, there's things going on, you order some blood work, well, hey, then you're going to take credit for that when you analyze it as part of your medical decision-making, maybe the next day when you go see the patient or you get those results. That's when you would take credit for it towards your E&M level. All right, go ahead, Simon. And you can buzz, again, the slides are coming out. Here's just a breakdown of definition around independent historian. Again, translation doesn't matter. If the patient needs a translator, you can't take credit there. And again, also, just one more point on the independent historian. It doesn't have to be a face-to-face for you to take the history. You can do it over the phone. You just have to make sure you're documenting it and that you are getting the history actually from that independent historian. All right. This is another area, I think it takes a little bit to get used to some of the, how does the risk level really work here? But again, I think once you dive in and you become familiar with it, it becomes easy in your mindset. in your day-to-day when you're seeing your patients. Hey, where does this fit in? So risk is really what? Like the probability and likelihood of something happening, and then the severity and impact if that event were to occur. And they talk about risk in the context of management of that patient for this encounter, right? And there's some great information. Again, I wish we could dive in. We are doing really comprehensive mastered training classes on this because there's a lot that goes into it. But for today's purposes, we really can't dive in too deep, right? So risk of what? Risk of morbidity, mortality. The two components of risk don't always causally link up, right? And I always love to give the example like, hey, maybe the likelihood and probability that you will have a HIPAA breach might be low because you have a lot of controls in place. However, if you did have a HIPAA breach, the severity and impact could be severe, right? So think of risk in terms of that. Risk comes in 4 levels. Minimal risk, and you can see that's really like, not much management there at all. Risks, superficial bandages for those, whatever conditions you're dealing with. Low risk, these are again, just examples. It's a guide, over-the-counter medications, physical or occupational therapy, minor procedures that don't really pose a risk to the patient. Moderate, prescription drug management, medication management, decisions regarding minor surgery for a patient that has identified risk factors, or decision regarding elective major surgery where the patient doesn't really have any identified risk factors. And this is important, I think. Diagnosis or treatment significantly limited by social determinants of health. This is a new area that was built into this table. I mean, we have the old risk table. We don't have that anymore. It's gone. But under medical decision making, this really impacts patients. Like, do they have access to healthy food or, great resident, do they have a place to live even, or access to medications? Those things all impact the patient's ability and their risk. High risk, drug therapy requiring intensive monitoring. Patients are really sick here. You're making decisions for, DNR. I want to point out here, really important. Risk is not only determined by the tests and procedures or management options, it's also determined by things that you may consider, like tests or procedures you may consider doing for this patient. However, based on that unique patient, the risk is too high. So you're not going to elect to do that. Or maybe the family says, doctor, run all these tests. And you go, no, it's not really medically necessary or appropriate because maybe that patient's on palliative care, right? Documenting that, and then documenting the reasons why you're not doing certain tests also increases the level of risk during that encounter. So that's important. It's not just about what you're doing, but also what you elect not to do. And there is a shared medical decision-making component here between the provider, the patient, the family. So a lot of times that drives what will happen in the end. So, all right, Simon. All right, here's the audit tool. This is where we're all going to have our aha moment. The light bulb's going to go off here about all the things I was just talking about. All right, this is GHA's tool. We kind of piggybacked and added in a section on the AMA audit tool guideline here. Again, this is a guide, right? So you can see in the left-hand column, we put in the level of medical decision-making. Again, we know those are straightforward, low, moderate, and high. You have to meet or exceed 2 of the 3 key criteria to pick a certain level. That's going to now line up with your codes. So here's the 3 categories. And we talked about the number and complexity of problems that you're addressing at the encounter. Column 2 here is the data section, and you can see it tells you here, hey, for a low level medical decision making, the data criteria is at least 1 out of the 2 categories listed here in this tool. And basically it says, hey, you have to get any combination of 2 from category 1 here. So I have to order 2 tests or review a document and order a test, or I have to take a history from an independent historian. So this is very specific here. And then again, low risk of morbidity or mortality to the patient. But let's go to the next slide and look at what moderate looks like. Here's where I think you're going to see, a lot of the types of conditions that you're dealing with patients that are in the nursing facility. So 1 or more chronic illness with exacerbation, 2 or more stable chronic illnesses, 1 undiagnosed new problem. Maybe the patient has altered mental status. Maybe they have, something going on. You don't know, you haven't diagnosed it yet. Acute illness with systemic symptoms. You guys are seeing UTIs all the time, right? That's a big factor in the nursing home. And then 1 acute complicated injury. So any one of these, and mind you, it says or here, fall into moderate level medical decision-making. And now the data, again, higher level, more data required. Now it says to get a moderate level data, you have to meet 1 out of the 3 categories. We went through the 3 categories in detail. Under the test section, it says, hey, now you have to get any combination of 3 of these. So any one of these problems or complexity of problems, I'm sure you're probably going to be ordering some tests or reviewing documents. You only have to have 3 unique components under category 1 to meet the criteria, or independent interpretation of tests, or discussion of management, or test interpretation with an external source or provider. And then under the risk level here, prescription drug medication management, we went through these in detail. I'm not going to go through them again for time purposes, but you can see. So, hey, here I meet the criteria under the number and complexity of problems. We're doing prescription medication. Boom, instant. You met a moderate level medical decision making. Okay, let's see, high level, 1 or more chronic illness with severe exacerbation. Probably you're seeing this type of stuff all day long. Acute or chronic illness or injury posing a threat to life. Now you can see the data section. Now for high level, you have to meet 2 out of 3 categories, 3 tests or documents or orders, or independent historian from category 1, and or meet the criteria under category 2 or 3, or in any combination, whatever is warranted by the situation. And then high risk again, decision for surgery, escalation level of care is important here. Maybe the patient's crashing, right? Usually our goal is to keep the patients out of the hospital, but sometimes they have to go. So that would be a situation where you would take credit for your E&M on that day for an escalation now from the nursing facility being admitted to the hospital. All right, let's see. Okay, time-based coding. Remember, you have an option, right? It doesn't matter. Patient 1, you can level by medical decision-making. Patient 2, you can level by time. So you've got to decide. I say get to know this stuff really good, and then you're going to know what's most beneficial for you when you're picking your levels. I'm going to go through this quickly so we have time to get to our questions. Simon's going to take us through the codes. If you're billing based on time, you've got to document the time in the medical record, right? You can only count time, and we talk about time under the new guidelines as all face-to-face and non-face-to-face time spent by the provider on that date of the encounter, right? So you can't take, wait, Simon, sorry, go back 1 second. You can't take credit for things today that you did yesterday, whatever. So it has to be on the same date of the encounter. Time has to be accurately reflect in the record. You can't say, hey, I'm billing a high level service and document like 1 paragraph in the note. That's never going to fly under audit. And you do have to indicate all the activities that you performed on that data service, right? You don't have to itemize, hey, I spent 5 minutes reviewing records, 10 minutes seeing the patient, with the patient. You don't have to do that, but you do have to document all the things that you're taking time for, and you do have to document the time, either the total time or CMS was like, hey, it's okay. You could document the start and stop time, and that would be appropriate too. All right, let's see. All the things that you can count towards time, anything you're doing for that patient, right? Whether you're there in the nursing home or you're not there, if you're working on things for that patient for that date, that encounter date, you can count it. reviewing notes, documenting, exam, ordering medications or tests, communicating with other providers. As long as it's not separately reportable, you can take credit for it, right? Same thing with care coordination, all the components of what you do. And hey, even the time you spend documenting, we've been asking for that for years. All right, Simon, next slide, please. The one few things you cannot count towards time. If you're with another patient, you can't count any of that time. If you're multitasking, it has to be time spent on that patient. No time for travel and no time for any other services performed by clinical staff, your nursing, only provider time. Okay, let's see. What do we have next here? All right, Simon, this is a great segue. And I'm sorry, I'm so wordy on this. We're super passionate about these changes. We love it. He's going to take you through the technical pieces of how the code's changed and what the definitions look like. And then just as he's going through these, keep in mind, like, hey, here's the code. That's a moderate or a high level medical decision-making there and the times that link up with this. So go ahead, Simon.
Okay, great. So I know we're running out of time here, but quickly for consultation must be provider initiated, and remember the 3 R's: request, render, and reply back. Any subsequent consultations will be considered as subsequent visits, and you can only bill 1 consultation code. So this is the rundown of consultation codes. There's no distinction between new and established patients, and it's based on medical decision-making or total time spent. So similar workflow for medical decision-making, straightforward, low, moderate, and high. Moving on to nursing facility services. Here we saw a deletion in the annual nursing facility assessment code 99218. So those of you that do report that code, you're now guided to report the subsequent nursing facility codes, which are 99307 through 99310. The nursing facility codes are used for patients in nursing facilities and skilled nursing facilities, including those that are psychiatric residential treatment centers and immediate care facility for individuals with intellectual disabilities. So one thing to note that there is no distinction in the code selection between skilled nursing facility and nursing facility care. Both locations will use the same CPT codes, and the only distinction that you'll be making is on the claim form by applying the correct place of service code. So for the nursing facility codes, when selecting a level of medical decision-making, the number and complexity of problems addressed at the time of the encounter are considered. So AMA describes that the principal physician is the admitting physician and the physician that will be overseeing all of patient care within the nursing facility setting. So be sure to review payer-specific guidelines to see if there's an appropriate modifier that will need to be used for the principal physician or the admitting physician. AMA has also developed a new high-level medical decision-making specific to initial nursing facility care performed by the principal physician, which is the multiple morbidities required intensive care. So the definition of multiple morbidities requiring intensive care is a set of conditions, symptoms, or functional impairments that are likely to require frequent medication change or treatment changes and reevaluation of the patient. So the patient in that case is considered to be in significant risk of worsening, whether it's medically or behaviorally, and the risk of readmission to the hospital is high. So this definition is specific only to the nursing facility services, and it is an element that is related to the number and complexity of problems addressed at the time of the encounter, which Alicia had discussed. So if a patient does have multiple conditions and intensive management is required by the principal physician, then the medical record should reflect that information. I just want to say one thing, that the definition and requirements related to the amount and or complexity of data to be reviewed and analyzed and the risk of complications of patient management are unchanged, and they will be required even if you have a high level in the number and complexity of problems addressed at the time of the encounter. So this is something new that AMA has added to the initial nursing facility.
Hey, and I just want to jump in here for a quick second. You know what that means, right? Your documentation has to reflect that. That's the requirement. If that's the high level, make sure that you are documenting all of those things using keywords, condition worsening, use those exact terms in your documentation to help support that level.
Yeah, so documentation will be your only line of defense. Like we say, if it's not documented, it never occurred.
Right.
So the initial initial nursing facility codes 99234 through 99306 may be used once per admission per provider, regardless of how many days the patient spends in the facility. So in this chart, we break it down based on the level of medical decision-making or total time spent on the day of the encounter. Also, initial services by other physicians who are performing consultations may be reported using the initial nursing facility care codes if the payer does not recognize the consultation codes. So again, there are 3 different CPT codes. And for example, CPT code 99305 will require a medically appropriate history and physical and a moderate level of medical decision-making or 35 minutes of total time spent with the patient, whether
Hey,
it's
Simon.
face-to-face or non-face-to-face.
I'm sorry, I just want to put a note out there that we're getting close to time. So if we could go through the most important codes in more detail.
Yes, so here we really don't see much of a change. Again, it's broken down based on medical decision-making or time-based. There was also no changes to nursing facility discharge. They are time-based codes, so make sure that you are documenting the total time spent on discharging the patient, whether the patient is discharged the day prior to it, leaving the facility, or on the day the patient leaves the facility. Part of the new 2023 guidelines, domiciliary rest home and custodial care have been deleted. Instead, you are referred to the home visit codes, and we saw also revision in those codes. So this section was revised to now include home or residential services that are not part of the facility. Home or residential services could be rendered in a patient's private residency, temporary lodging, or short-term accommodation, including hotels, campgrounds, cruise ships, and so on. And similarly to the nursing facility, they are broken down based on the level of complexity of medical decision-making or time-based codes. One thing to note is home or resident services are broken down based on new or established patients. And to finally wrap up the presentation with prolonged services, there have been a lot of deletions and revisions here, so we're not going to get into too much details because AMA and CMS still need to finalize their code selection, but just note that all prolonged services codes are added in conjunction with the highest level of time-based codes. So the initial time unit of 15 minutes should be added once the time in the primary E&M code has surpassed by 15 minutes. And I will turn it back to Alicia and Rob to wrap up our presentation.
Woo, we skirted in over the finish line right there in the nick of time. Again, just really quick. I know if we have a minute or two to get to some questions, but hey, the overall goal and objective of the updates are to let providers see patients, document for clinically appropriate reasons, and not to support their level of services billed, decrease the administrative burden. I can't, listen, get this right. It's so important. Take the time, be confident, get the training, lose the fear when it comes to picking your levels of service. Just a quick lesson learned from since the implementation of 2021 to now, our audit data across the industry shows that providers are undercoding. So you're still like, not really sure. I'm going to defer to the lower code. Don't do it. Be confident. Pick the level that's going to get you reimbursed for the services you're rendering and not put you at risk for overpayment. So I'm going to punt this over to Rob, and hopefully we have time for a question or two.
Sure, I'm trying to answer what I can in these boxes popping up. Yes, it's going to come to you. The recording's going to come to you. We're going to send it to where you register, what you use to register. We'll get them out. It takes a little bit of time to get these recordings back in and edited, etc. But so let's go over some fundamentals. So I'm using my time-based coding. Do I still need to pay attention to what I'm documenting in terms of what I'm doing in the encounter?
Yes, yes, yes. I think we covered that in detail.
Yeah, I think we're good on that. Some of
Make
the
sure you
typical
document
ones.
the time and everything you're doing.
Yeah, and so I think given the time here, we have a few questions that have come in. We will get to those unless you can see anything that you can kind of answer quickly.
I think too, we're going to put them together and we'll post them on the website, like the Q&A, or we'll get back to anyone who has asked a question. We'll get back to you.
What might be helpful is for those who didn't get to the CMS stuff yesterday, is there anything you can share that people were kind of most concerned or requesting about that would apply to this group? I'm not sure if it does or not, but
not really. Big questions came in on split shared.
Okay.
Yeah, so yeah.
All right, very good.
We thank everyone so much for tuning in today, and please let us know if you need help or have any questions on this.
Thank you, everybody.
Take care.
Thanks.